a very topical presentation on hepatitis B. So the GECKO programs are hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. And these fellow programs actually run every second Monday at 6 o'clock. And importantly, we want this to be interactive, so the chat will be open for questions. So really, we want you to really take part in this, be actively engaged. And Elizabeth is going to, or Liz is going to now start with the presentation. And I thought because hepatitis B is really quite a complex disease entity, it might be worthwhile to, during the presentation, take a pause and take questions. So Liz, over to you.
So, hi everybody. I'm speaking on Hep B, and my moderator is obviously Prof. Spearman. This is just a basic outline. We'll just go through the epidemiology, virology, some of the serological markers, and then move on to the treatment guidelines in some other special situations. So I think this is a map that everyone has seen multiple times. It's a map showing the global prevalence of chronic hepatitis B. Remains a massive problem worldwide. The global prevalence is about 250 million, and there are obviously areas that are have a higher prevalence where it is endemic, and that includes the Africa region, which is where we are, and then Asia and the Western Pacific and Southeast Asia region. Just to be aware that while there are many countries that have traditionally been considered places where chronic hep isn't a major issue and have a much lower prevalence, such as the Americas and Europe, it's important to realize that prevalence there is changing and it is actually becoming more of an issue, and that, you know, as people move from high endemic areas to these lower endemic areas, their rates of chronic hep B are actually increasing. So up to 95% of people with chronic hep B or chronic hep C don't actually know that they are infected. The tragedy of this massive population infected with hep B is that it actually is that it's entirely vaccine preventable, and that vaccine has been around since 1982. So seroprevalence varies in different countries depending on sex, ethnicity, and then where people are born, so rural versus urban areas.
Sorry, Liz. Liz, they're battling to hear you. Can you maybe go closer to the laptop?
Sorry, everybody. Just shout if this is a problem still. So the seroprevalence varies depending on sex, ethnicity, and often birthplace, whether it's rural versus urban. A prevalence of more than 8% is considered endemic, and that's usually in areas where infection is established early in childhood. There are increasing concerns that there are more and more deaths related to secondary complications of chronic hepatitis B. And that is largely related to an aging population and increasing cofactors such as metabolic complications and metabolic associated steatotic liver disease. Chronic hep B, the reason that we are so concerned about it is that there is a significant risk of both cirrhosis and the development of hepatocellular carcinoma. And it's important to realize that hepatitis B causes hepatocellular carcinoma in both cirrhotic and non-cirrhotic patients. And so assessing them for treatment, follow-up, and cofactors is vitally important. Okay. So in sub-Saharan Africa and South Africa, we have sub-Saharan Africa, about 64 million people who are estimated to be infected with chronic hepatitis B. And in South Africa, that equates to about 2.5 million people. So our prevalence varies widely throughout the country. As I said, it varies between provinces and between urban and rural areas. Um, Prior to the introduction of the hepatitis B vaccine into our immunization schedule, our prevalence varied in different areas from 0.3% up to 15%, which is obviously very high. So in 1995, the hepatitis B vaccine was introduced into the vaccination schedule, and it's given to children at 6, 10, and 14 weeks. But there was never a catch-up vaccination program, and there has not been, up until recently, a huge push for perinatal, screening of pregnant women and birth dose vaccine. We also obviously have a significant population of people infected with HIV, and prior to the introduction of ARVs, which are now very robust drugs, there were many people co-infected with HIV and Hep B, and HIV resulted in a much more aggressive disease course. Following the introduction into the immunization schedule, our prevalence dropped and is now sitting at about 3.5%. But if you look at data, that hasn't changed much over the last decade. And so that probably reflects the need for PMTCT and birth dose vaccine if we're going to further impact that number. So our chronic hepatitis B prevalence is driven largely by perinatal infection. Perinatal infection almost guarantees chronicity and results in a 25% increased risk of death from cirrhosis or HCC if male and 8% if female, which is very, very high. So I'm sure everyone is aware that WHO has a global hepatitis strategy, and that is to eliminate hepatitis as a global health threat by 2020. They have very ambitious targets of 90% reduction in new cases of chronic hepatitis B and C, 65% reduction in mortality. And in order to achieve that, it requires at least 80% of treatment eligible people to be on treatment. So considering that most people don't know they're infected, this is a very ambitious target, and obviously was curtailed somewhat during the COVID pandemic. So as I alluded to earlier, transmission and the timing of transmission and acquisition of hepatitis B is crucial in determining its chronicity. It is a very contagious virus, 100 times more contagious than HIV, and can survive outside of the body in dried blood for up to a week. So I've highlighted there under transmission the two ways in which our prevalence is really driven. It's mother to child transmission, which is described as vertical transmission, and then horizontal or familial transmission, and that's usually between household contacts, often young children, perhaps at creche or play school, running around, playing outside, getting cuts, and maybe being exposed in that way. Other modes of transmission are sexual contacts and then percutaneous exposure, so needle stick or IV drug use, but that's not what is driving our large numbers. So if you are infected perinatally, the chance of developing chronic hepatitis is 90%. It feels like it's almost guaranteed. And so we really want to try and address that in terms of preventing mother-to-child transmission. If you acquire hepatitis B as a sort of a young child between 1 to 5 years old, you have a 20 to 50% chance of developing chronic hepatitis B and a 50% chance of clearing it. And then if you acquire it as an adult, less than 5% of people will develop chronic infection. You're almost guaranteed to clear the virus. Just looking at the graph that's from the WHO guidelines, you can see that the reality is if you're infected as a baby or young toddler, you are almost always completely asymptomatic. There's no indication that you have been infected, and your chance of developing a chronic infection is massive. But no one seeks help for it because there's no indication that you've been infected or sick. Okay, so just looking at the virus itself, it's a DNA virus, and that I think is a crucial piece of information. We learned about Hep C last time, which was an RNA virus. This is an envelope partially double-stranded DNA virus, and the important thing about that is the viral DNA is integrated into the host DNA, which is one of the huge reasons why it is so difficult to cure and why we essentially don't have a cure for hepatitis B. It exists as a relaxed circular DNA with a complete negative strand and a partial positive strand, but the virus, it has a DNA polymerase in it, and so it can repair that DNA to form a complete DNA structure. So there are at least 10 different genotypes, A to J, and they vary. Their incidence varies across the world. We have a significant number of genotype A and A1 subtype, to be exact, whereas in Asia they have a higher incidence of genotype B and C. West Africa has a higher incidence of genotype E. And all of the genotypes respond to the nuke treatment, but they have varying risk factors in terms of development of hepatocellular carcinoma. And then there is some variation in response to treatment from the various genotypes. The hepatitis B virus enters into hepatocytes, and that's where it replicates. It replicates and forms new variants exclusively in hepatocytes. It's in itself is not hepatotoxic. The liver injury occurs when the immune system recognizes it as foreign and tries to clear the virus by attacking the liver cells. And so the liver injury is really secondary to an immune response rather than the direct action of the virus itself. Part of the development of chronic hepatitis B is due to T cell exhaustion. And yeah, that's part of the mechanism of it becoming chronic. So just to look at the structure again, clearly it's got a lipid an outer lipid bilayer membrane. It's then got a capsid inside, and inside that capsid is the double-stranded DNA with the DNA polymerase. Just out of interest, the surface antigens, we just talk about surface antigen, but there are large, medium, and small surface antigens, and there are tests that can quantify surface antigen, although, well, I don't know if anyone else has them. We don't have them, but there are tests that quantify the surface antigens, not just a positive or negative. All right, so the actual DNA codes for 4 different proteins. It's the S, P, X, and C protein. So the S protein is the outer layer, and it forms the lipid layer, which coats the nuclear capsid. Just in terms of viral replication, the virus is able to secrete full viral particles, complete viral particles, but there's also formation of subviral particles, which consist just of this protein, and that's also triggers the immune system and aggravates the T cell exhaustion that results in the chronicity. So the P gene then codes for the polymerase, and that allows the virus to perform its translation and transcription. The C gene codes for the core and the core proteins and the E proteins. And if you look at the bottom there's that region called the pre-core region. So if there is a mutation in that pre-core region, some of the viruses aren't able to then form this protein, and so you don't get the E antigen, and that would account for some of the patients who are E antigen negative. When we look at the phases of hepatitis B, you'll note that there are some patients who, despite having high viral replication and high viral loads, will be E antigen negative. And that is because of the mutation in that particular part of the C protein. And then finally, there's the X protein. We don't measure that, but it is involved in modulating viral replication and certain host functions, and is considered part of the oncogenic property of the virus. So this is just looking at the life cycle of hepatitis B. You can see at the top there, it enters the hepatocyte via the NTCP receptor. So that is the sodium taurocholate co-transporting polypeptide. And it's important just to take note of that, because that is one of the areas that are sort of one of the targets of some of the newer therapies. So it binds to the NTCP receptor and enters the hepatocyte. There's uncoating of the capsid, and the capsid itself is then moved into the nucleus. Once it is in the nucleus, the relaxed circular DNA is repaired to form this triple C DNA. And this is a crucial component, again, of how this virus works and how it persists in the hepatocyte. So this triple C DNA is complete. It's like a mini chromosome, and allows for complete transcription of mRNAs and pregenomic RNA, which then can be translated into all the proteins, the pregenomic RNA, which will eventually allow formation of complete new viral particles. So the pregenomic RNA undergoes reverse transcription to DNA. Once the capsid is formed and the DNA has been transcribed, it is either coated and released, or some of those are then shuttled back into the nucleus to ensure that the pool of triple C DNA is not depleted, and to ensure that there's always some of that triple C DNA in the nucleus. Part of the viral DNA, as you can see, is also integrated into the host DNA. And again, this is why it is so difficult to completely eradicate hepatitis B. At the top there, you can also just see that there is a release of fully formed viral particles, but there's also those spherical and then oblong subviral particles, which is just the S antigen that are released. And so you can have S antigen levels which are very high, that reflect both S antigen from viral fully formed virus particles, but also the subviral particles. Even though the subviral particles don't have the DNA, they are still a marker of transcriptionally active process in the hepatocytes. And so and adding to the high levels of surface antigen, that's why high levels, sorry, I'm now getting tongue-tied, but high levels of surface antigen are a reflection of just actively transcribing processes within the cell. I'm going to stop talking about that. The X protein, as I said, modulates some of the cell processes. And then, as I said, the DNA is integrated. So just looking at the hepatitis B serological markers, we order these all the time, and I'm sure everyone knows about them, but just to go through them again. So the surface antigen is a marker of infection. It's the first marker to appear. And it, as I have just tried to explain, is a surrogate for transcriptionally active CCC DNA. If you have a surface antigen that persists for more than 6 months, that is the definition of chronic hepatitis B. The E antigen, again, is a marker of active viral replication. But as I said, if there is a mutation in that pre-core region, one can be E antigen negative, but still have very active viral replication. So then just going to the antibodies, the hepatitis B surface antibody is essentially indicates either recovery of an infection or immunity from vaccination. If you are vaccinated against hepatitis B, you will just have a positive surface antibody. If you have been infected and cleared the virus and developed immunity, you will have a positive surface antibody, but you will also have a positive core antibody, reflecting that you were infected at one point. Hep E antibody, so generally Hep E antigen disease is considered those are patients with high viral replication, often very high viral loads. And the transition from Hep E antigen to Hep E antibody is considered a positive step in that it usually indicates some element of immune control and the decrease in the active viral replication. As I said, though, if you have a mutation in that pre-core region, you can then be E antigen negative, but actually still have very, very high viral replication. So as I said, if you are infected, your core antibody will always be positive. In an acute infection, the IgM is strongly positive. But once you are out of the acute phase, and you clear the infection, your core will be mostly made up of IgG. The reason why it's important to differentiate is that the IgM will help you try and decide whether this is an acute infection or not. So if it's positive, it delineates an acute infection. The one proviso is that you can actually have chronic infection and then at times have a hepatitis flare where your IgM may become positive. It's useful if you have a virologist that can give you an indication on whether the core IgM was high and strongly positive or just mildly positive. And that can help you decide on whether it's an acute infection or a flare. All right, so just quickly looking at acute hepatitis B, this description is of acute hepatitis infection in an adolescent or an adult. As we've already said, if you're infected as a child, you almost always are asymptomatic. So in acute infection in adult patients, the incubation period is usually 4 to 12 weeks, and many are still asymptomatic. People can develop a fairly typical viral prodrome, just feeling lethargic, unwell, having some malaise or myalgia, but having sort of high swinging fevers is quite uncommon. Most patients will clear the infection without progression to severe liver failure or liver impairment. And not everyone, but some will develop jaundice and more significant symptoms of feeling quite unwell. And that's being called serum sickness. There's a very small subset of patients who may develop fulminant hepatitis and acute liver failure. Again, it's much rarer, but if you acquire HIV and hepatitis B at the same time, you have a much higher risk of developing fulminant hepatitis. Again, the diagnosis of acute Hep B is made with the surface antigen that's positive and a core IgM that's positive. Just to be aware that if you have a fulminant hepatitis and your liver sort of just implodes, you might not, your surface antigen might be negative because the hepatocytes have completely necrosed and unable to secrete the surface antigen. So just in terms of treating an acute infection, essentially is supportive bed rest, high caloric diet, and avoidance of any other additional hepatotoxins. I think bed rest is underestimated as something that's very important in liver disease. Not everyone needs antiviral therapy, but people who develop any signs of liver failure, whether that's an encephalopathy or a significant coagulopathy, heading north of 1.5 in an INR, or for people that are having a very protracted course with prolonged jaundice and feeling very unwell for sort of more than 4 weeks. Those are the patients where one would consider antiviral therapy. We recommend treatment with monotherapy, and that can be lamivudine, tenofovir, or TAF, or entecavir. We often would choose to use lamivudine in the acute, in an acute infection. It brings down the viral load a bit faster than tenofovir and has much fewer side effects if the patient is becoming very unwell, and much easier to dose in renal impairment if they are very, very sick with a fulminant hepatitis. The concerns about using lamivudine are just sort of long-term viral suppression and the development of resistance, but that isn't really an issue initially. Resistance only develops a little bit later. And so lamivudine is an excellent choice in these patients. If a patient does unfortunately fall into that very small subgroup of fulminant liver failure, they need aggressive management, ideally in ICU, and may need consideration to be listed for an urgent transplant. Again, this is vanishingly rare, but it is important to be aware of. So this graph is from a paper published in the Lancet in 2023, which is a very useful overview of hepatitis B, but it just shows you the serological markers and how they change over the course of the disease. So the first marker to appear is the surface antigen, which then eventually before 6 months is replaced by surface antibody. The core IgM rises, and as it settles, it's then taken over by the core IgG. Just note around that 6-month mark, there is a small window period where it might be that the core IgM is the only positive serological marker. And so it is just important, if you are worried about someone with acute hepatitis or liver disease, and everything is negative, if you are worried, to do the core IgM. In terms of the basic serology for chronic hepatitis B, it's fairly simple. Essentially, they have a surface antigen which becomes positive and doesn't go away. They don't develop surface antibodies, and they have core antibody, which is positive. Initially, largely IgM, and then IgG. And yeah, so that is relatively simple in terms of diagnosing it. The HBV DNA will then be detectable because they have an ongoing chronic infection. And then these are the patients where we measure the E antigen and E antibody to try and see at what phase of the infection they are, what their risk of progression is, and who would need treatment. So I just want to speak a little bit now about the different phases of chronic hepatitis B. And this slide is obviously from EASL, and it has the old terminology at the bottom and the newer terminology at the top. And essentially, patients with chronic hepatitis B are divided into E antigen positive and E antigen negative patients. And in each of those, you either have hepatitis B infection, where you have a normal ALT, or you have a chronic hepatitis, where your ALT is raised and there's a marker of inflammation and activity. So, I mean, the new nomenclature is relatively simple to remember. I think you either E antigen positive infection or hepatitis, or you E antigen negative infection or hepatitis. All of them will be surface antigen positive. The E antigen, obviously, according to the different, either positive or negative, all of them will have detectable HBV DNA, just depends on how high it is. The E antigen positive patients traditionally have much higher DNA levels. But DNA level doesn't on its own indicate a level of activity in terms of liver inflammation. So just to bear that in mind. And then the final phase is occult hepatitis B or resolved hepatitis B infection, where patients are surface antigen negative, but they haven't developed the surface antibody, and they will be Core positive, and they have very, very low levels of detectable DNA. These patients are generally well, their ALT is normal, they don't need any specific treatment unless they are being immune suppressed, and particularly if they are receiving something like rituximab, then they are patients that can flare and would need prophylaxis. So I just want to Prof. Spearman has taught us over many years, I think as students and now as regents and fellows, about the different phases of chronic hepatitis B. And it really is like a story. And I think if you think of it as a story, it makes a lot more sense, and it isn't this oddity that one has to try and remember. So if we start at the initial phase of people who would be E antigen positive with chronic infection. So they don't have a hepatitis, it's just an infection. These are often people who've been infected perinatally, very early on in their life, and their immune system wasn't able to engage with the hepatitis B, and so it established itself very easily, and there are very high levels of DNA virus. These people often have viral loads in the millions. I've seen one recently of 1 billion, but their ALT may be completely normal. And this, the old terminology, I think, can be quite helpful in understanding. Essentially is considered immune tolerant. So the person is infected. There is clearly viral replication with a very high viral load, but the immune system is essentially tolerating the infection and isn't activated. As the person then perhaps grows up a little bit, the immune system may then become aware of this infection and try and clear it. And so you can see in that graph there's the ALT can go up and down as the body tries to clear the infection by attacking the hepatocytes. And because of that, the DNA may go up and down as some of the hepatocytes are damaged, some of the virus is cleared, but the body is unable to clear the virus completely. And this phase can last for years, and people may enter this phase and go back to immune tolerant, or they may enter this phase and the immune system does get control of the virus, and they then move into the next phase called the immune control phase. So important just to realize that people can move through the phases sequentially, but they don't have to go through every single phase, and they can go back to a different phase. So once the body has decided that it wants to try and get rid of this virus, there may be multiple attempts by the immune system to try and get rid of this virus, and that results in quite significant inflammation and damage to the liver. And if the people stay in this phase for quite a while, you can imagine that they may develop quite significant fibrosis and can even develop cirrhosis. And if the immune system is able to get some control of the hepatitis B infection, one would then move into the immune control phase, or the E antigen negative phase of chronic infection. So the E antigen is converted to an E antibody, indicating some level of control and decrease in viral replication. And during this time, the DNA, the HBV DNA, then becomes much lower, and the inflammation settles because there isn't this chronic active aggressive immune response. If patients have moved quite quickly into this phase, they may have no fibrosis. But like I said, if they have gone through multiple almost flares of trying to clear the virus and end up in immune control, they can be cirrhotic even in this phase. And so while we often may decide that patients who are E antigen negative with chronic infection don't need treatment because their ALT is normal, their viral load's low, that is why it is important to assess for fibrosis, because these patients even may have significant fibrosis and cirrhosis. And some patients may remain in this phase, but as I said, there is this mutation that can occur in the E antigen, and so patients in the pre-core region, so patients may be E antigen negative, but progress to severe inflammation again and a hepatitis, and they essentially then develop what we call immune escape, where they are escaping the immune system again, the viral load goes up and the ALT may go up. So those are the phases where we would traditionally treat patients, because they're easy to see that they have abnormal ALTs as a marker of inflammation within the liver. I can stop there. Prof. Spearman will make a comment.
Thanks, Liz. I think just to add something more to the hepatitis B surface antigen. So originally, the surface antigen actually helped you to decide when we were treating with pegylated interferon whether you were going to respond. What is now showing that if your level is greater than 1,000, particularly greater than 3,000, you are at a higher risk of developing liver cancer in the future, and also potentially helps you to decide when we get to functional cures, we are more likely to have functional cures. And then in terms of the serology for the surface antibody, one of probably the best mark of past infection is your hepatitis B IgG core, because often if you acquire hepatitis B perinatally or in early childhood, you will tend to lose that surface antibody. So the IgG core is probably your best marker for past infection. But otherwise, I think you've covered everything very well.
Okay, so sorry, I realized we need to move swiftly along. So just, I've put the slide in, I think I've spoken to it briefly, but phase 5 or occult hepatitis B is an important thing to just bear in mind, particularly when you are going to immune suppress people. Again, most of these patients will not need much in terms of follow-up, and may be very well and often found incidentally during a screening process at the blood bank, or if you are going to immune suppress them. But if they have reached this phase and they're cirrhotic, they will need ongoing surveillance. I'm going to leave this here just as a reminder if anyone wants to look at it later, but just what the different serology may look like in the different phases or different clinical scenarios of hepatitis, when an acute infection, recovery, and then the different phases of chronic hepatitis. A small note just to remember that there are extrahepatic manifestations of hepatitis B, and they can be seen both in the acute infection or in a chronic infection. And so just to be aware of them and to look out for them, as they may need much more aggressive treatment. Any extrahepatic people with extrahepatic manifestations, it's one of the indications, for treatment, but some who develop more aggressive forms, such as polyarteritis nodosa or some of the glomerulonephritis, cryoglobulinemia, might need more aggressive treatment. Okay, so just when you are then faced with a patient that has chronic hepatitis B, it's important to make a very thorough assessment on your initial meeting. Important things to consider in history is that particularly a family history of cirrhosis and a family history of HCC. Then important just to look for any comorbidities that would have an effect on the course of this disease, particularly metabolic risk factors and possibility of underlying mast cell. I think it's grossly underdiagnosed. Just to think about alcohol and their alcohol use history, any immune suppression that they may be on, and then, as I said, the extrahepatic manifestations. It's a good opportunity when one sees a patient with chronic Hep B just to discuss screening partners and children particularly, and to try and break that cycle within families. On examination, obviously looking for any features of chronic liver disease, extrahepatic manifestations, and then complications of their comorbidities. And then baseline special investigations, looking at sort of the full blood count, looking at the white cell count, HB and platelets, looking for any markers that would suggest hypersplenism as a complication of cirrhosis. We want to know what their UNE is, particularly if we're going to start them on tenofovir, to have baseline LFTs, because it's going to guide us in terms of whether they need treatment or not. INR, and it's very useful to have an alpha-fetoprotein. Some people run an alpha-fetoprotein that's maybe 2, 3, 4. Some run a higher alpha-fetoprotein that's maybe 8, and it's repeatedly 8. But if someone's alpha-fetoprotein is always 2 to 3, and suddenly it's 8, and then suddenly it's 12, even though those are very low numbers, those patients need to be they need a more aggressive search for the development of early HCC. These baseline bloods are also useful in terms of calculating the APRI or FIB4 scores, and part of the assessment of anyone with chronic hepatitis B is trying to assess their degree of fibrosis. WHO has updated their guidelines and updated their cutoff values for the APRI score, and that's largely been based on work out of Africa. So that has been very encouraging in the new guidelines. Hepatitis B serology and looking at things like the viral load, the E antigen, the E antibody can also help you try and make decisions in terms of treatment. It's always useful. I mean, you have to know that the patient is HIV positive or negative, because we're going to put them on antivirals if they are requiring treatment. Hepatitis C and D as cofactors are important. We have a much lower incidence of hepatitis D in our country, but we have a lot of immigrant patients who have immigrated from other countries, and so just to be aware of that. And then it's useful to assess hepatitis A immunity, and if they're not vaccinated, to vaccinate them. some places may have access to transient elastography. The machines are very expensive, and so it's not expected that everyone would have one available. And that's why the WHO has been quite clear in terms of using APRI cutoffs. It's useful to get an ultrasound at some point with a portal venous Doppler. And then just to note that while previously everyone who had chronic Hep B had a liver biopsy done to assess fibrosis, that is obviously unnecessary now and is mostly used in research. But if you are concerned that there's a significant cofactor or things just don't make sense or go according to plan, a liver biopsy is something that may still form part of your assessment. So just a reminder of the APRI score. It uses AST and platelet count, and a score of greater than 5 is equivalent to a transient elastography reading of more than 7, and that equates to F2 fibrosis or higher. Equates to cirrhosis, and that would be equivalent to elastography reading of 12.5 kPa. So just to remember those cutoffs, and APRI is something that is really easy to do, and if you don't have transient elastography, everyone should be able to do that for these patients. Just to note, in terms of your history and assessment, these are particular risk factors for HCC that we want to try and tease out in each person. So as people get older, if they're male, family history, and then just to note this sort of explosion of mast salts that particularly in patients with diabetes is a very significant extra additive risk factor for HCC, and to note it's a risk factor in the absence of cirrhosis. And then obviously patients who've had a longer duration of infection with very high viral loads, even if they don't have very abnormal liver functions, may be at a higher risk of developing HCC in the future. Certain specific genotypes put you at higher risk, and genotype A1, which is what's prevalent in our population, puts you at a higher risk at a younger age. Patients who are E antigen positive because of the high viral replication, as Prof. Spearman said, the high surface antigen levels, and then those with the basal precore and core promoting mutations. Just in terms of liver factors, if you have persistently raised ALT as a marker of inflammation, if you are cirrhotic from any cause, if you are co-infected with HIV, Hep C, or Hep D, those put you at increased risk, and then any other liver disease can increase your risk of HCC. Environmental factors like aflatoxin exposure and then smoking and alcohol are also additive risks. So then looking at treatment, the goals of treatment are essentially in acute infection to prevent subacute or fulminant liver failure. Just a note that there was previously a concern that if you gave patients antiviral therapy during acute infection, you may lower the chance of them clearing it and may increase their risk of developing chronic infection. That has now no longer thought to be an issue. So if there are any concerns in an acute infection and of liver failure, it's worth considering giving them lamivudine. In chronic infection, our goal is to induce long-term DNA suppression and get normalization of the ALT as a reflection of decreased inflammation in the liver. And ultimately, that is to prevent disease progression to cirrhosis and or the development of HCC. Those are obviously the main goals. And then there are other things, obviously, in terms of preventing on-route transmission, reactivation of flares, treatment of extrahepatic manifestations, and then ultimately we would aim for E antigen and surface antigen loss. Although with our current treatments, those are almost never actually happen. So the slide again, I know you've seen it, but just to highlight that whether you are E antigen positive or E antigen negative, if you have a hepatitis, you are going to require treatment because there's at least moderate to severe liver disease as reflected by the elevated ALT. Okay, so last year the WHO put out new guidelines to try and simplify who should receive treatment. And the aim of this is really to get more people onto treatment. Over the last, I don't know, decades, we just haven't got close to treating enough people. And so this really is an effort to upscale treatment. There are arguments that some people have put forward that why don't we just treat everyone? But I think if you look how many million people need treatment, that isn't necessarily practical. But if we definitely do need to upscale our treatment. So anyone with significant fibrosis or cirrhosis, that is why it is really important to try and ascertain the level of fibrosis of your patient. Doesn't matter what their E antigen status is, what their ALT is, what their DNA is. If they have F2 or higher fibrosis, they need treatment. And that, as I said, that can be done using the APRI score or transient elastography. Anyone with an HBV DNA level of more than 2,000 and even a single abnormal ALT can be put on treatment. Just to bear in mind that the levels of normal ALT in males is 30 and females is 19. It's not the 40 that is on our lab forms. And so, yeah, if you have access to HBV DNA testing and if the level is higher than 2,000 and the ALT is abnormal, they need treatment. Then regardless of the APRI score, the DNA, the ALT levels, if they have a co-infection with HIV, Hep C, or Hep D, they need treatment. If there's a family history of cirrhosis or HCC, they need treatment. If they are on immune suppression, if they have significant comorbidities, particularly things like diabetes and MASLD and hemochromatosis, those put you at much higher risk of HCC, even in the absence of cirrhosis. And so anyone with those cofactors should be on treatment. And then, as we said, extrahepatic manifestations. And then if you, in places where there isn't access to HBV DNA levels or a huge battery of tests, if someone is surface antigen positive and they have an elevated ALT on 2 occasions, they should be put onto treatment. And so, as you can see, this will really increase the number of people who have access to treatment and should be put on treatment. I've just put this in. Thank you to Prof. Spearman for the slide, but it's just a copy of the WHO algorithm. It's essentially this, but it's clearly put in an algorithm, and if you want to refer back for reference. Okay, so getting on to the treatment, there's been development of treatment from interferon to our very potent nukes, which we have now, which are excellent in terms of treatment and actually have relatively few side effects. Interferon was originally developed in the early 90s, and that was later replaced by pegylated interferon, which just had better pharmacokinetics. And so it's a less demanding infusion schedule. Lamivudine is one of the first nukes that was used, and it does treat hepatitis B, but obviously there's the risk of developing resistance. And our later drugs, tenofovir and TAF, are excellent with almost no resistance described. So we really do have access to excellent drugs. Again, this slide just looking at the barriers to resistance over a 5-year period, significant number of patients will develop resistance on lamivudine, whereas TDF and TAF remain excellent options. When we talk about response to treatment, we can talk about virological response, and this is something we monitor by checking the HBV DNA, and what we want is people to have undetectable HBV DNA on treatment. A sustained virological response would be someone who maintains a low HBV DNA off treatment, but that really is not something that we should engage in patients I don't think we should engage with patients on stopping treatment while we just have the nukes as therapy. Almost no one stays suppressed, and they are at risk of quite significant flares if we're stopping and starting treatment. There's serological response where you get e antigen loss and e antibody development, and surface antigen loss and development of surface antibodies. But like I said, that's not a realistic goal for most people on just our nucleoside drugs. There's biochemical response with normalization of the ALT, and then histological response, which we generally don't monitor. Just as an extra thing, I'll speak a little bit more about it at the end, but essentially our aim would be to try and develop a regimen which would provide a functional cure. If you look at this, it shows you sort of what cure means in different contexts, and ultimately getting rid of the triple C DNA and the integrated DNA, which are in the liver, is what will always be a very, very tricky, if not impossible, task. And so what a lot of research is aimed at now is what we would define as a functional cure, and that's undetectable surface antigen and unquantifiable HBV DNA for at least 24 weeks after completing a finite course of therapy. And so while we aren't there yet, this is where we would aim. Ideally, we really do want surface antigen loss, because surface antigen is associated with higher risk of HCC. So unfortunately, currently our best options are the nukes, which would give us essentially almost it's not a cure, it's sort of, but what may be a partial cure. You can have undetectable DNA, but you will still always have the surface antigen, core antigen, and the integrated DNA in the liver. So our nucleotide agents, I think everyone's very familiar with. We've been using them for years because of our enormous HIV programs, but they are also excellent options for hepatitis B. They have varying barriers to resistance and different side effects, but first line recommendation is either tenofovir or entecavir, or if there is a contraindication, to then use TAF. Entecavir is generally quite a lot more expensive, and we have easy access to tenofovir, and so we don't really use entecavir. But it is described in guidelines and as one of the first line options. Yeah. So essentially, we want to choose a nuke with a high barrier to resistance, such as tenofovir, and it's going to be used long term once we start it. There are guidelines about this. Possibly stop, will never develop surface antibodies and won't be able to stop it. And the risk of stopping and starting is the risk of flares, which can be very dangerous. And so I think it's important when you counsel people about starting these drugs that they know that this is lifelong treatment. Just to note that obviously there is a risk, there is a concern of renal dysfunction and around osteoporosis and bone mineral density with tenofovir, and so TAF, tenofovir alafenamide, is recommended for patients that are in those risk categories. Tenofovir is an excellent drug against Hep B, suppresses wild type and lamivudine resistant mutants. It's recommended as first line, and yeah, like I said, we have TDF and we have TAF, and it's just depends on the salt that it's attached to. Tenofovir disoproxil has side effects which are largely renal and bone related. You get a tubulopathy, and you lose quite a lot of phosphate, and that can cause bone related issues. For older patients or adolescents, those with osteoporosis or renal dysfunction,
Liz, you seem to have frozen.
Hello. Is my screen disappeared? Okay, so this is just can you hear me? I'm going to continue.
Go back one slide, Liz.
Sorry, I don't know what happened.
One more. Go back one more. Yeah. So we got yeah. So the next slide will be fine.
Sorry, I'm just talking to myself. So just a note, between TDF and TAF, tenofovir has a 25% oral bioavailability. So you need a slightly higher dose of 300 milligrams, and it's distributed in a wider range of tissues as opposed to TAF, which is more concentrated in the white blood cells and hepatocytes where it's needed, and so you can use a much lower dose. It's essentially to do with the salt that it's attached to. Tenofovir disoproxil is completely cleaved from the salt and so spread quite widely across multiple different tissues, whereas the TAF is only a small amount is removed from the salt, and that allows it to concentrate in the liver and the white blood cells. Just looking at outcomes of TAF versus TDF, their outcomes are essentially the same. And so you use the drug based on what is needed in terms of the side effects. Entecavir, I'm not going to spend too much time on, but essentially it is a good drug. But if you have used lamivudine and are resistant to lamivudine, your response with entecavir is much poorer. And so we wouldn't use it in patients who had already failed lamivudine. Lamivudine is an excellent drug. It has very few side effects. It's cheap and it's much easier to dose adjust in renal dysfunction. But the concern is that you do develop resistance, particularly for the YMDD mutation. And at 5 years, more than 50% of people will have resistance. Emtricitabine isn't approved for Hep B in the USA, but obviously it comes with some of our combinations and can be used and is active against Hep B. A quick note on combination therapies, so whether it's useful to use tenofovir versus TDF, FTC, or LAM as a combination, there isn't really benefit in using a combination therapy. So the only time where we would recommend it is obviously in HIV positive patients, people who require PrEP, or in places where you have easy access to the combination, but not easy access to monotherapy. Then there's no harm in using the combination, but there isn't any real benefit. If just a note that if someone has been on lamivudine and they are failing that and their viral load is increasing and you now want them on tenofovir, it's best to then use the combo and get their viral load undetectable again. And then if you would like, you can continue them on monotherapy. If you stop the lamivudine and switch to tenofovir, there is a chance that you can get a flare of the wild type virus. Essentially, the nukes are go-to. They are excellent in terms of their viral suppression and are relatively easy to use. Pegylated interferon is something that was used previously, is not used really much anymore, and is quite difficult to administer. It has lots of side effects, but in the future, it is almost certainly going to form one of the drugs used in combination therapy to try and get a functional cure. And so I think it is important that we are aware of it. Most of us will not have used it, but we do need to know about it. patients really struggle with feeling unwell on interferon. They get flu-like symptoms, they have fatigue, they can get significant thrombocytopenia, neutropenia, and there are some complete contraindications to interferon use. So fulminant liver failure, some of the more immune-mediated extrahepatic manifestations, and obviously pregnancy, one wouldn't use an interferon. Monitoring, we generally would want to monitor patients 6 monthly. We want to check the usual sort of basic bloods, the liver functions, AFP, and then the viral load. Ideally, we would want to do an ultrasound with an alpha-fetoprotein 6 monthly to review patients to ensure that they aren't developing a hepatocellular carcinoma. Unfortunately, doing that only once a year means you might miss an early HCC, and by the time you do it after a year, they have quite a big tumor. So ideally, I realize it's not always practical, but ideally you would want to do an ultrasound every 6 months. Annually, one may consider doing transient elastography, and you can measure calculate their APRI just to look and see if they are developing fibrosis. And then certain more ill patients may need more frequent follow-up initially. For patients who are not on treatment, they initially need to be followed up 4 monthly. There's a HepsiNet group looking at data from Africa, and about 40% of patients on their initial bloods could not be classified into a particular stage of one of the 5 stages of hepatitis B, and so it wasn't clear on whether they may need treatment or not. And so it's useful in patients who don't initially look like they need treatment to follow them up at least 4 monthly for the first year to make sure that they aren't having background flares. If they look like they are truly E antigen negative or positive, just infection and not any evidence of a hepatitis. If they're E antigen negative, they can be followed up annually, and if they're E antigen positive, they need to be followed up 6 monthly. As I said, screening for HCC is really important, and the point of that is to try and pick up early cancers that would be for curative intent. HIV and Hep B co-infection has a more aggressive disease course. They have an increased risk of toxicity with the multiple drugs they're often on, including IPT and Bactrim. That's obviously for patients with lower CD4 counts. HIV Hep B mortality is 2 times greater than HIV Hep C mortality. But it is encouraging that we have excellent drugs that treat both. And so I think the aggressive disease course can hopefully be modulated by getting people onto treatment earlier. Hepatitis C is an increasing problem, particularly with IV drug users. It accelerates fibrosis and the progression of liver disease. If you are dual infected, hepatitis C is the sort of more dominant virus, and a greater contributor to the liver disease. But as you treat it, you can get significant flares of Hep B. And so it's very important to treat these patients hepatitis B. Hepatitis D is a defective virus, luckily not very prevalent in our population, but it is a very aggressive disease course. And so for patients that do come from highly endemic areas, it is important to check. Sorry, I'm nearly ending. As I said, the important thing here in terms of us having a greater impact on our prevalence is dealing with mother-to-child transmission. And so the highest risk on patients who are E antigen positive and who have very high HBV DNA levels. The WHO has made strong recommendations about PMTCT, and our government has luckily begun to adopt the policy of surface antigen screening for all pregnant women in South Africa. And the aim is then to provide prophylaxis and birth dose vaccine to the babies of women who are Hep B positive. Ideally, the screening should be done as early as possible in the pregnancy. If you're not vaccinated, ideally we should vaccinate these women, but they should then be followed up, and the babies get a birth dose vaccine followed by 2 to 3 further vaccinations. Just to note that breastfeeding isn't contraindicated. So the updated recommendations from WHO are that if you have e-antigen and DNA testing available, anyone with a DNA higher than 200,000 or a positive e-antigen needs tenofovir prophylaxis from the second trimester in pregnancy. If you don't have access to those things, then anyone who is surface antigen positive should be given tenofovir prophylaxis. Ideally, the woman should be assessed for her need for treatment outside of pregnancy, and if she qualifies to continue it. If not, and she would be eligible to stop treatment, one can consider stopping if she, once the child has received their full course of immunizations. If, however, the woman is planning future pregnancies, it may be prudent to just continue the prophylaxis. I don't need to go into this, but it's a note just on vaccination. It's very, very safe in pregnancy, in anyone, just about. It's cost effective, and antibodies are long lasting. If one is embarking on a mass vaccination campaign, it's also not necessary to test people's antibodies before you vaccinate them. You can just vaccinate them. Anyone who doesn't respond can get a double dose of the same vaccine, or we have plasma-derived vaccines, which have higher response rates. And then lastly, just looking to the future, our aim is to try and move towards this concept of a functional cure where you lose the surface antigen, plus minus develop surface antibodies. And in order to do that, we are almost certainly going to have to use sort of a multifaceted approach. So these patients are likely to need triple therapy, something which will stop the viral replication, something that can try and address the triple C DNA, and something that will boost the immune system to try and aid in viral clearance. And that's where the interferon would come in. In red here, you can see the different areas where new drugs are being tested. So there's the entry inhibitor, and that's the one that we use for hepatitis D as well. It's probably worth just knowing a bit about, but I will stop there because we are now way over time.
Thanks, Liz. I mean, that was really extremely comprehensive coverage of a very complex topic, and something that we really all of us need to know something about. There were some questions from Prof. Naidu, which I think is worthwhile addressing. In terms of occult hepatitis B, do you always need to be on TDF prophylaxis? So I think if you are just on a short course of steroids for, 2-3 weeks, I don't think you need it. If you're having any long-term immunosuppression, then you need to be on prophylaxis. Obviously, it's going to require determination whether you can actually monitor the hepatitis B DNA levels. If you're on immunosuppression or chemotherapy and it's say for 6 months, the recommendation is that you continue the tenofovir prophylaxis for at least 6 months after completing the immunosuppression or chemotherapy. But if you're on rituximab, it must be for at least 1 year. So I think the safe thing is to think these patients do need tenofovir. And then the other question, I think, VG, I think Liz has already answered that too. So no place for pegylated interferon now in standard treatment for hepatitis B. But I think if we're looking for functional cures, pegylated interferon will probably still play a role. So thanks to everyone to staying on for that extra 50 minutes. I think it definitely was worthwhile. We covered everything that you need to know and should know. I think you can see that in terms of the phases of the infection, you need to know that, and the WHO is really a public health response to hepatitis B. So really thanks to Liz, thanks to ECHO University of New Mexico and ECHO India for their technical support. Obviously, thank you for the Gastro Foundation for supporting these webinars. And our next webinar is planned for the 17th of February, and that will cover hepatocellular carcinoma. So thanks everyone and have a good evening.